Respected chairpersons, learned audience, Assalamu alaikum and very good evening. My case is the situation can change, make a decision. Passion history, 57 years gentleman, CCS free, hypertensive and smoker, ECG was normal, echocardiography shows normal echocardiography with ejection fraction 59%, ETT was positive in stage 2. This is the coronary angiogram. Left main free of significant disease. LCX is free of disease, but LAD has got 90% stenosis in its proximal segment. D1 is good size vessel and 90% stenosis at its origin. RCA is free of disease. EBU catheter, 3.5 into 7 French catheter taken, both LAD and D1 wired with floppy wire. Predilatation done in LAD with 2 into 12 millimeter balloon. Predilatation done in D1 with 2 into 12 millimeter balloon. This is the image after predilatation. After predilatation, decided to perform the mini crush technique. Taken in position 2.75 into 21 millimeter drug eluting stent in D1, 3 into 28 millimeter drug eluting stent in LAD. D1 stent deployed, stent balloon pulled back and going to higher pressure. During removal of balloon from the D1, unfortunately, guide catheter disengaged from left main ostium and the stent and wire comes out from the LAD. What is the challenge in this situation? Again, failed to cross the guide wire. Wire can pass under the stent strut. Stent unable to pass in the main vessel due to protrusion of the D1 stent. We don't have any imaging modalities like IVAS and OCT. What is the next strategy? What we have done, again, guide catheter engaged in the left main ostium, try to negotiate wire to LAD through D1 stent. We succeeded, negotiate wire to LAD through stent. Successfully wired to LAD through D1 stent, confirmed with 2 into 12 millimeter balloon, passed through the stent strut. After successfully wire pass, now we decided to perform the culotte technique. Stent strut open with 2 into 12 millimeter balloon. Image after stent strut open. A 3 into 28 millimeter drug eluting stent position in the LAD. Stent deployed in LAD. Image after stent deployment. Port done with 3.5 into 8 millimeter non-compliant balloon. After port, D1 again rewired with floppy wire. Stent start open with 1.25 into 10 millimeter balloon. Sequential kissing balloon dilatation done with 3 into 12 millimeter in LAD, 2.75 into 12 millimeter in the diagonal non-compliant balloon at 12 atmosphere pressure. Report done with 3.5 into 8 millimeter balloon at 6 atmosphere pressure. This is the final result. Conclusion, in culotte technique, we use two stent that leads to full coverage of the bifurcation at the expense of excess metal mass of the distal end. Rewiring of the both branches through the stent strut is difficult and time consuming. Culotte technique probably gives the best coverage of the carina. Final kissing is mandatory when treated bifurcation lesion with double stent strategy. Kissing should be sequential. Thank you for patient help.
Thank you for your brilliant case. As because you have decided upfront double stent strategy, angle is small and narrow, and that is why you have chosen mini crush. You have done excellently, but uh, falling in this problem, keeping out of the wire and stand from the LED, once again re-enter, this is very difficult job. What you have overcome. What you have overcome very
Thank you,
nicely.
sir. God
Uh,
help me. This is
That's right. And there are two systems. Previously, we did it keeping one stent in the main branch and another stent in the side branch because it requires wide bore catheter. And nowadays, what we are doing, keeping the balloon in the main branch and side branch stent. And by the balloon, we do the crush of the, then we implant the main branch stent and then recross and then do the kissing. And here kissing is also in step kiss and then pot.
Yes.
But you have shown very nicely. Thank you.
Thank you.
That is a very good alternative, but stent, then put a stent in the LED, recross and do that. But anyhow, whatever the technique is you use, ultimately the result, final result is the answer. Whatever the technique, final result, if it is good with long-term outcome, that is good.
Thank you.
Correct.
Sir,
You mentioned that the patient has class 3 angina. So did the patient need to go for an exercise test before a coronary angiogram? My first question.
So he did the angiogram, he did the ETT, that was positive at his test 2.
sir,
Class 3 angina, is it
sir,
necessary?
sir, patient from outside.
Okay.
ETT done outside. I have not done the ETT. Sir.
Okay. Number 2 is, once in a mini crash situation, once you inflate the side branch stent, it holds the main branch stent. It is very difficult to move the main branch stent after you inflate the side branch stent. So how strong the traction was there to pull the main branch stent out of the coronary artery?
Yeah.
No, but
Actually,
it is very difficult. The side branch stent holds the main branch stent in the, yeah,
No,
it is, unless it is a very strong traction, it is very difficult to move the main
actually,
branch.
sir, what happens? The angulation of the diagonal that determined. It is very much difficult to push the main branch stent, but easy to pull it back.
After recrossing,
Hello.
when recrossing the main branch, so do we push through the stent start or behind it?
You pass a balloon.
Balloon.
Balloon easily pass through the wire.
Or
So, it,
after passing it. Money.
so we are
Doctor-
running short of time. Our next
Dr.
speaker,
Iqbal.
Dr. Arifur Rahman.
Sir, 1 second, please.
Yes, come.
Yeah, Iqbal, a very good case. What was the reason why you did classical crush here? You crushed stent with the you're supposed to crush stent with the stent, right? So why you? This is classical crush. We don't do it anymore. Yes, we always crush stent with balloons.
Yes.
Then recross and do first kissing and second kissing, because if we do classical crush, recrossing and the dual kissing rate is 75 in the best hand. So I think we should do balloon crush rather than classical crush. Yeah, I think you got the point, Iqbal.
Sir, sorry, sir, again.
So yeah.
So, as Dr. Mir Jamaluddin said, stent the diagonal, crush the diagonal stent with a balloon, not with a stent. So that is the classic teaching of a classical crush or even mini crush. So do it with a balloon first and then recross, and then you can actually get a better kissing balloon inflation, and then you can do a crush.
But the other important point here to me, you cross diagonal stent, right? You did ballooning, yes, and then what did you do? You put a stent, right?
Yes, no, sir, I first introduced a balloon. Balloon easily passes through the.
Yes, but did you do kissing before stenting? Sorry, did you do stenting? So, yeah, after predilatation of stent strut, you had better do kissing, first kissing.
Yes.
Because you don't know if you are true strut and under strut. You don't know it. Nobody knows it. So I think for the best result, we should do first kiss, stenting main artery and second case. This would be the I think important
Yes,
point.
sir. If 2 keys, result is very good in case Coulot.
Yes.